as a quick introduction, Eric is a co-founder and cryomedic at International Cryomedics Experts, one of the standby providers that handles cases outside of the US and internationally. Eric, please take it from here.
Great, thank you. First of all, pleasure to be here. Thanks for inviting me to speak about standby stabilization and transport. We're really excited about where this is going, especially when it comes to field cryopreservation. And I really like to talk to everybody about some challenges that we've experienced when it comes to normal SST, and some lessons learned that we've learned when it comes to FCP. You know, currently the current method of SST, in which we know when it talks about deploying a team to the patient's bedside, having the team readily available with equipment, it's very effective when there are no time or distance challenges. And all the cases that we've been on, there's always been some sort of time or distance challenge. And that really means that those are the components that we take a look at and see how can we eliminate those time and distance challenges. If you have the foresight, though, you know, it's very effective. But getting that team to the location, the bedside of the patient or the member, whichever one you want to call it, is really the challenge. You know, as we talked about before, you've heard some people say the goal really is to have 24/7 operational readiness and infrastructure with vehicles and trained staff in every region. Jacob talked about having his vehicle ready in a certain location, and ideally we would like to have a facility and in every state in every country, but as you know, that's just not feasible. So when we talk about an optimal cryopreservation, we're really talking about getting the resources there at bedside, the standby, the stabilization, and the transport piece of it. Now, what I'd like to do kind of really is talk a little bit about each of these components and how that applies. When we talk about the standby portion of it, the standby is, although most people think that we're just kind of putting the team there at the patient's bedside and we're just waiting for legal death to occur. While that's true, there's other things that are going on in the background. So we really talk about preparing for the legal pronouncement, the logistics of getting the team and the equipment there first of all, setting up the equipment, preparing for the logistics after we do the standby, during the stabilization, how we're going to arrange to get the patient from whatever facility we're in into a facility that is ready for surgery. All of these things take a little bit of planning. And again, that takes time in order to do that. In an ideal world, you have enough time to prepare for all of this, and you're going to plan for each of these things. What we really want to do is we want to stand by as close to legal pronouncement as possible. That means we want to be at the patient's bedside, right at legal pronouncement, so we can begin our procedures to minimize that warm ischemia and even cold ischemia for those people that are being put on ice without the rest of the standby. It's very difficult to predict the date and times of legal death. I mean, sometimes we don't know that. We would like to have the luxury of knowing this in advance and be prepared for us to be there. But oftentimes we've seen that that's been not the case. And so, we're always in a rush to get to the patient's bedside. We're scrambling to get our equipment, there, whether it be by ground or by air. So really, we want people to be conservative. We want them to be a little conservative when it comes to deploying the team at the patient's bedside. Again, we want to be there as early as possible, ideally before legal pronouncement. That's the best case scenario. And obviously, we've had some challenges when it comes to COVID. COVID has really put a damper on how we operate, and especially when it comes to international travel, we've seen quite a few challenges when it comes to COVID. Really, what we're talking about here is time and temperature, the two main components which we're faced with. Obviously, the time piece of it, and then the temperature, eliminating that warm ischemia is extremely important. So the stabilization, and this is where I think a lot of people get confused. For me and my personal experience, really the stabilization encompasses quite a few different components. So what I really do is kind of break that down. Really, the stabilization involves rapid cooling, CPS, and then medication administration, and then an organ preservation washout. This is typically what we're used to, or cryonicists are understand when it comes to a stabilization. There's a lot of research that indicates that remote blood washout is superior to leaving the blood in the patient, which is very true. But it's also evident that prolonged ischemia is not beneficial to the patient. It could completely eliminated when there's smooth transition from stabilization to cryoprotected perfusion, and that's really what we're going to talk about when it comes to FCP. But this is kind of typical scenario when we think about stabilization. It's the cooling, it's the CPS medication administration, and then the organ preservation washout. So again, I break it down on the three components of the stabilization and to what we're familiar with, because really there's a lot that goes into the stabilization piece of it. When we talk about the rapid cooling of medications, typically what we do is we do rapid cooling via wet ice. A lot of people get confused when they say, ice in itself. Are we talking dry ice or wet ice? We're really talking about wet ice. We can't introduce cold temperatures of dry ice just yet because we don't have any cryoprotectant in the patient. CPS, medication administration is going to mitigate some of that ischemia. And then a field washout, like we talked about before, which is organ preservation fluid. And this requires a surgeon and a perfusionist to be there at the bedside or at the facility in which we transport the patient to in order to perform the surgery to do this washout. We'll talk a little bit about some similarities when it comes to FCP and this field washout, and why it might be superior for when it comes to FCP. The last piece of the SST is the transport. And really what we're talking about is how we're going to get the patient from the location in which they're either, facility in which they had legal pronouncement into the facility in which we provided the washout, and how we're going to get them to the long-term storage facility. And that's either going to be by air or by ground, depending on where we are. It could be by commercial flights or by charter flights. And then the last piece of it is going to be a domestic flight, or are we talking about international? All these things really provide or pose additional challenges to us, because each one of these components is a little bit different. Again, when we talk about what we're trying to accomplish here, time and temperature. Each one of these things here, you can see, is going to be a little different when it comes to time. Obviously, ground is going to be a little bit slower. The commercial flight is going to be a little bit slower than a charter flight. And then obviously, domestic is going to be a lot quicker than international flights. So when we're talking about a washout, organ preservation washout, we're still faced with the time constraints on this. Transportation to cryonics facility could be, again, I saw Jacob's nice vehicle there, and it's very impressive. And obviously, you would like to have one of these vehicles to take the patient to the facility to perform the cryoprotectant infusion. But that always isn't the case. And so when we do get there, obviously we have to do surgery. We have to get vascular access. The base perfusate is circulated, and the cryoprotectant is slowly introduced over about 2 hours or so. And again, this is performed at the cryonics facility. So it's not performed at the bedside or at the facility that's near bedside. We actually have to transport the patient to a cryonics facility in order for us to do this. So what's the best case scenario? Well, again, it works very well if you have a fully trained and equipped SST team that's nearby and available. And again, time and temperature is really what we're faced with here. So we have to have somebody that is nearby. The transport time from legal pronouncement is short, depending on which cryonics facility you are signed up with. You'll have different requirements as far as the time from legal pronouncement to transportation. To the introduction of the cryoprotectant. Ideally, you would like that to be less than 24 hours, but we've seen some cases that have been extended beyond that. And you're also assuming that commercial air transportation is readily available. And as I mentioned at the beginning, COVID has really put a damper onto the readily available transportation. We've experienced that ourselves with international travel, very difficult to get to certain countries, a lot of paperwork that was needed, and we had quite a few challenges. Here in the U.S., we have two major cryonic storage facilities, Alcor in Scottsdale, Arizona, and the Cryonics Institute in Clinton Township, Michigan. So if you're taking a look at the continental United States, you can see that we can pretty much reach all of the U.S. Fairly quickly. We also are faced with a few challenges with COVID just interstate here in the U.S. So what's the reality of SST? Well, the reality of it is that the legal death, we want to make sure that we're there prior to the legal death, but often that is not the case. We're called at the last minute. It takes a lot of time in order for us to get to the patient's bedside, and oftentimes we're there post-mortem. You have a trained and fully equipped team. Most of the time, that's limited availability when it comes to fully equipped and trained teams. Most of the time, you're working with a lot of volunteers. I talked about the proximity to the cryonics facility. There's not many of them around the globe. And so we have that distance challenge in getting the patient from the bedside to the cryonics facility in order for us to perform the cryoprotectant infusion. And then the commercial air transportation, weekends, holidays, getting the paperwork available to transport is not always readily available, and so it makes it very difficult. So this is really the realities of SST. It's in a perfect world, things go very smoothly, but in my experience, in our experience with our team members, is there's always going to be hiccups, and we have to overcome those challenges. So the biggest one for us is really when it comes to the cryoprotectant perfusion, it must be performed within 24 to 48 hours of legal death. And going back to what I said before, time is of an essence. So the time portion of it is really what we're challenged with. Again, we're performing this cryoprotectant perfusion at the cryonics facility. So for those of us who've seen some of these things in the past where we don't have that time, the luxury of time, the typical outcome is usually a straight freeze. And that means we weren't able to get to the patient's bedside to perform the stabilization. We weren't able to introduce cryoprotectant in the field. And it ends up where the patient goes into a straight freeze. We put them onto dry ice and maybe ship them to the cryonics facility for long-term storage. So how do we overcome some of these things? And this is really where FCP comes into play. And you might have heard Ashwin talk a little bit about FCP. He's done a lot of research when it comes to FCP. And I really think that this is the future when it comes to standby stabilization and transport. So what is it? We're really talking about the replacement of blood and tissue water by solution of cryoprotectant agents. Really what we're talking about is the quality of care and how we're improving that quality of care when we eliminate the prolonged cold ischemia that's typically associated with remote cryonics cases. So, and again, if we don't have facilities that are nearby, we would consider those remote. If we have to take an airlines to the location of the patient, that's a remote location. What we're going to do is we're going to cool the patient. We're going to get the patient to dry ice temperatures fairly quickly. And that means that we would introduce the cryoprotectant before getting them to dry ice temperatures. But this is important. The dry ice temperature is important because what it does, it really buys us time. And then the packaging, prepare the patient for transportation. It will be done on dry ice. But we'll talk about some of the things as far as it eliminates some of those logistical challenges too. So the field cryoprotectant is really reducing the time between the legal death and the start of the cryoprotectant. We're not waiting to transport the patient from the bedside to the cryonics facility to perform the field cryoprotectant. We're actually doing it there near the patient. So sometimes we take the patient from their home or from the facility, and we will use a local funeral home, and then we'll introduce the cryoprotectant there in the field. If the time of pronouncement between legal death and the start of cryoprotectant is minimized, again, We can place the patient into long-term cryostasis without incurring unnecessary cold ischemia injury, and that's really what we're trying to prevent. So the standby of it really remains the same. Again, we encourage people to be very conservative when it comes to getting the standby team there at bedside. The cryoprotectant is introduced in a gradual manner. It's cooled as it's being infused into the patient. Refractive index is monitored, and then the flow rates are controlled by measuring line pressure. It is a little different than using, a perfusion inside a controlled environment such as an operating room, but we've seen that it's been very effective. So I mentioned stopping time, and that's really what we're talking about. We're talking about stopping time and allowing us to have the luxury of making the arrangements to get that patient to a cryonics facility, because they're not readily available, and they're not, we don't have those readily available around the globe. We cool them to dry ice temperatures for shipment to a cryonics facility, and we've eliminated that time urgency. We've seen that we were able to keep patients on dry ice for weeks at a time, and then ship them to the cryonics facility. Now, then, this is not a perfect world. Also, there are some shortcomings. Temperature and pressure cannot be precisely controlled during this infusion. It's a gravity-fed system. Again, it's not in a controlled environment like an operating room, but it is effective. The cryoprotectant concentration rises more rapidly, which is because of the gravity-fed system. We try to even it out with a teeter-totter, but it's not precise. The cephalon is perfused, while the rest of the body will not receive cryoprotectant. And this is some confusion also. Some people think that we're talking about a whole body cryoprotectant. We're really talking about the cephalon only. And then dry ice is essential. We have to have dry ice wherever we are. So if there are some shortages of dry ice, or maybe we're in a remote location that doesn't have dry ice availability, this poses a problem to us too. We haven't seen that ourselves. Dry ice is fairly widely available. Excuse me. So we haven't run into that problem just yet. So really what we're talking about is a choice. The choice is between traditional SST versus FCP. When you have time and distance constraints, typically you're looking at a straight freeze, or if you're looking at FCP, we're talking about a cephalon cryoprotectant, in which your brain is going to be protected with the cryoprotectant. And this is really kind of the difference between the two. What type of risk are you taking when it comes to traditional SST, and what type of risk are you taking or eliminating when it comes to FCP? It's interesting to think about when it comes to the FCP, and we talk about just cryoprotecting the cephalon only. But what we've found is that there is really no reason why we can't do whole body. And so one of the things that we're looking at now is whole body field cryoprotectant. If you take a look at the traditional SST, we're washing out with organ preservation fluid now. Why not just introduce the cryoprotectant at the same time? So the evolution, I think, and probably the experts who are looking into this, is that we may be able to do whole body field cryoprotectant. It's going to require a lot more cryoprotectant. Obviously, when it comes to transportation, we're going to have to take a lot more cryoprotectant with us. But there might be better outcomes when it comes to whole body field cryoprotectant. So just in conclusion, with FCP, we eliminate some of those challenges when it comes to the time, the distance, and really what we're talking about is, preventing that warm ischemia, preventing this cold ischemia, and introducing the cryoprotectant right away in the field without the necessity of the operating room and the surgeon perfusionist inside the OR. And thank you very much.
Eric, thanks a lot for the talk. One question, one person asks, you mentioned that ideally there should be a preservation facility in every state or in every country. Why not a handful of the biggest cities like San Francisco, New York, London, and so on?
Yeah, great question. If we could have strategically placed facilities, that would be that would be ideal. For us, I think we're talking about really getting the team there in a timely manner. And then from the time or from the location of the patient's bedside to the cryonics facility, you have to take that in consideration. So if they were strategically placed around the country, I would say that that would probably be sufficient. But again, there's a huge investment, a lot of resources that go into that, and that may not be feasible based upon the numbers of patients that are being cryopreserved at this time.
Right, and then another question, which is more a general question, not necessarily but towards you, but I think you might have a good insight in that as well. Are you aware of anybody who's actively working on making legal changes? I mean, since you do international standby, you probably come across a lot of different legal systems. Like, what's your insight into that? Is there a huge difference, or is it mostly the same? What's your opinion?
There is a big difference depending on which country you're in. So even within the same country, there's differences. Canada, for example, there's differences within the country itself when it comes to the views of cryonics. So for the most part, we're seeing that we're able to do this in the majority of the countries, but there are some challenges when it comes to the legal aspects in different countries. So I would suggest that you start researching your country and the legal challenges within your own country, and reach out to some groups that may be in your country also, some cryonics groups. They may have some more information.
Mm-hmm. And one question just came in, so maybe last but not least. So it's actually two questions that I think can be combined into one. So one is, Eric, what is the availability or the variability and of availability of surgeons and perfusionists worldwide? And the other one is, how many professionals do you have available globally for FCP?
I can't answer the first question. I don't know that. There's a lot of surgeon and perfusionists out there. Are they well versed when it comes to what we're doing when it comes to cryoprotectant perfusion? That I really can't answer. I would assume that it's very low. Very few of them are familiar with this. And then as far as our availability, we have a team, a local team here in Phoenix, Arizona, that consists of 6 team members. But we also have team members that are located throughout the United States, in Texas, in the Denver area, and the Seattle, Washington area, California, and in Florida. We also have some people that are in Hawaii. These teams are familiar with standby stabilization and transport. And we will typically send those teams with an expert that has been on many cases, either myself or another one of our team members, to be the lead. And typically it's a team of 4 people. But we have a pretty significant group of about 16 people who are readily available to be deployed.
Perfect, Eric. Thank you so much. Maybe see you later at the Q&A, because then we can answer. There's a few more questions coming in. But due to the timing, we would move on to the next talk.
Right. Thank you.